From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery, speaking today with Dr. Walter Weber of the Breast Center at the University Hospital in Basel, Switzerland, on behalf of the Taxus study team. Our topic today is the association of axillary dissection with systemic therapy in patients with clinically node-positive breast cancer. Dr. Weber, welcome.
Hello, Dr. Cochran. Thank you very much for having me. It's a great pleasure.
I am really excited for our listeners to have the opportunity to learn more about the Taxus trial. I understand this is a European-based multi-center randomized clinical trial. Can you give us a brief introduction to the trial's purpose and how the trial sites were selected?
Yes, I'm happy to do that, Dr. Cochran. Taxus is a phase 3 non-inferiority trials comparing axillary dissection to axillary radiation in patients with clinically node-positive breast cancer, both in the upfront surgery and in the neoadjuvant setting in case of residual disease. All patients undergo tailored axillary surgery, which is a novel concept designed to selectively remove positive nodes in a limited manner. And after this, they are randomized. It is true that it's a European trial as of to date. We run it at 40 sites in about 6 countries. But we are currently expanding and evaluating new sites, for example, in South Korea and the United States. So it's becoming more and more global. We did not select the sites other than asking them if they perform surgery on patients with clinically node-positive breast cancer on a routine basis. This is a pragmatic trial, so we follow usual care as much as possible. And this includes that we want to generate data that are then applicable really to all of those sites.
I'm very enthusiastic about the concept of this becoming an international trial, not just a European regional one. That's a really fantastic prospect.
Yes, we really had to transfer the role of the sponsor and the clinical research organization from the initial lead study group, the SAKK, to the Oncoplastic Breast Consortium, the OPBC, which is a global enterprise. And this now allows us to really expand our trial network. And we're just as enthusiastic about this as you are, because all of this really then increases applicability of our findings to all sites around the world.
Dr. Weber, one of the things that I noted was the timing of when the Taxus trial started enrollment and when the targeted end date for enrollment was. And I immediately thought, oh, the pandemic was in the middle of all of this. And I can't help but wonder if the pandemic impacted enrollment for Taxus at all.
Well, that is a good question, and I don't think it really did impact the performance of the Taxus trial in a measurable way anyway, but it could potentially have had something to do with this financial crisis that hit the initial lead study group, the SAKK, the Swiss Group for Clinical Cancer Research, that then had to suspend most of their trials, which brought us in a difficult situation, and we really had to transfer sponsor and clinical research organization to the Oncoplastic Breast Consortium and the University Hospital of Basel in a very short period of time to avoid that patient accrual would collapse. And this could have had something to do with the pandemic.
I want to move specifically to the cohort study that's in this issue of JAMA Surgery that was embedded within the Taxus trial. And why were you interested in the question of the impact of axillary dissection on systemic recommendations in breast cancer patients with clinically positive lymph nodes?
Right, so that is a key question. We're investigating the oncologic safety of omission of axillary dissection, and there is more than one mechanism how this could affect oncologic safety. One is the obvious one, that we would leave cancer behind without dissection that may not be adequately controlled by radiation. But the other one is that the omission of dissection could lead to an understaging of the patients. So clinicians would not know the exact number of positive nodes anymore, and this in turn could jeopardize or limit systemic therapy or the effectiveness of systemic therapy, and that in turn then could affect oncologic endpoints. So we needed to know this from a trial perspective.
That makes a lot of sense to me. You already talked a little bit about one of the big challenges you ran up against with the overall study. Were there any challenges that were specific to either designing or executing this specific cohort study?
No, that was a quick run, let's say. Everybody agreed that it's important. We could embed it from the very beginning. So it was a truly prospective study. And we could also relatively easily raise the funding necessary for that sub project. The major obstacles or challenges we face are just the ones that come with a surgical phase 3 international trial. When it comes to funding and patient accrual, that keeps us very busy.
Absolutely, both of those things would. I can't help but wonder, Dr. Weber, were you surprised by any of your findings?
Yes, and just as much reassured. We were, first of all, surprised that the cancer was locally so advanced in many of these patients. First, in the group without axillary dissection, 1/3 of patients had PN2 disease, locally advanced breast cancer. And in the group with axillary dissection, that almost doubled to 60% of patients having PN2 disease. We were further surprised that this understaging in the group without dissection was not associated with any difference in systemic therapy. We figured, since the magic line of having 3 positive nodes or 4 positive nodes that is used as an indicator for systemic therapy traditionally, and that is now used when evaluating applicability of landmark trials for molecular testing like Responder or MindAct, or even abemaciclib from Monarchy. Even though that line is crossed in many patients, almost 1/3 of patients, there was absolutely no difference in systemic therapy. And that was surprising indeed.
Here is my real, kind of how do we make this practical question I have for you. I know that you all are still conducting, obviously, the Taxus trial, but based upon what you learned with the results from this particular study, are you ready to stop recommending completion axillary lymph node dissection to breast cancer patients with clinically positive lymph nodes?
Yes, that's a fair question. So until we stop recommending axillary dissection as standard care in these patients, we have to wait for the publication of the primary endpoint analysis, which we expect in 5 to 6 years. However, I think the findings are highly clinically relevant today because they do clearly make the point that you should not go back and perform axillary dissection for staging purposes to determine the total number of positive nodes to help medical oncology indicate systemic therapy. And that is a question that is very prevalent these days. First of all, always having been there by this magic line that I've just mentioned, but now boosted by these trials that I've already mentioned, the Responder, MindAct, and now Monarchy. And this is making a clear point that if the knowledge of the exact number of positive nodes that comes with axillary dissection with a 25% lifetime risk of lymphedema, if you're not using this in patients with clinically node positive breast cancer, how would you be using this in patients with clinically node negative sentinel node positive luminal breast cancer, which is where this question comes up regularly now in the tumor boards around the world. So that is where the true clinical relevance of this published cohort study is coming from.
Right. And I appreciate you noting the very real and common morbidity associated with lymphedema in these patients, because that's really something that we see having a significant ongoing impact on their day-to-day lives.
Absolutely. And this is also the main driver of the TAXIS trial. We decided not to take lymphedema as a primary endpoint or quality of life. That was for methodological reasons. So we wanted to first prove that oncologically it's safe to omit axillary dissection. So we took an oncologic endpoint, disease-free survival. But really, this is all about improving patients' quality of life. And one of the major aspects of this is the prevention of lymphedema. Absolutely.
I noted as I was doing my homework to get ready for our conversation that this was the second study that was nested within Taxus, as I understand it, that both of these were pre-planned and were embedded within the trial itself. Should our listeners anticipate additional nested trials, or is enrollment in Taxus complete or nearly so, allowing you to move to your more definitive analyses and questions?
Well, we just today crossed the halfway of patient accrual. So we had patients 750, 751, and 752 randomized today of a total number of 1,500 patients. And this tells you that we need a couple of years more to complete accrual and about 5 to 6 years more to actually publish the primary endpoint. We do have some more clinically relevant questions that we pre-specified to look at during this time, which is mostly associated with this novel concept of tailored axillary surgery. We want to see how well it works. We want to see what the role is of imaging-guided localization of the clipped nodes, how many nodes are palpable, how effectively is this procedure selectively removing positive nodes, and so on. We're looking at patterns of care across the countries in use of neoadjuvant therapy. But of course, the big deal is now to complete the trial and then the follow-up and then publish this. And I'm sure that this will be a major and one of the very final milestones in the history or the development of axillary surgery de-escalation.
Fantastic. Dr. Weber, I very much appreciate your time today. Thank you so much for spending some time with me talking about the Taxus trial and specifically about this cohort study on axillary dissection and systemic therapy.
The pleasure was all mine, Dr. Cochran. Thank you very much again for having me.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.